All right, so abdominal presentations. This is abstract number 200, and we're assessing the clinical acumen of predicting acute appendicitis in the emergency department. This is a study, an observational study. Who here is a better clinician now than when they started? That's what this study shows. All right, so they took the surgical team, not in the United States, but they took a surgical team, and then they asked them how confident they were that this patient in front of them had appendicitis. And they started from the most juniorly trained person to the most senior member of the surgical team. And as you went up the surgical team, clinical acumen, or one of my favorite words, Gestalt.
Gestalt.
Love saying that.
Not as good as penumbra.
Penumbra, oh, that's a good one too. Gestalt got better. And they could predict it. They had almost 200 patients in this study. It's a small study. It's from Ireland. There could be some workup bias. There could be some referral bias. There could be something called a double gold standard, which means not every person in the study got the gold standard test to confirm whether or not they had the diagnosis. So in this case, out of 180 people, 23 didn't get a CT scan. And so that's called a double gold standard because it was like, hey, we'll just call them up later and see how they're doing. Okay, so that's called a double gold standard. So there's some problems with this, but I think from a standpoint of does this make sense? Yeah, it does make sense. I think I'm a better clinician now, now that I've been practicing for almost 30 years compared to when I started.
And more importantly, our clinical judgment is better than any clinical score, right? The score they used was only 61% sensitive, and even the most junior people were much higher than that.
Yeah.
The one caveat I do think is important there is that it is harder in women. Men tend to, there's less ovaries and things in that area to confuse it with. I had a case last week who I was convinced was going to have appendicitis. I mean, she was peritoneal, point tender in the right lower quadrant. We called surgery before we got the CT because I was so convinced it was going to be appendicitis, and it ended up being just an ovarian follicle that had ruptured, but she had like peritoneal kind of signs. So again, our threshold for being accurate is going to be a little bit less in women, but your physical exam regardless is going to be better than any clinical scoring rule.
And this study was done in adults. I don't use an appendix score. I have used an appendix score in children, but more for teaching purposes and showing to parents, this is why we're not rushing to get a CT now, this is why we're going to watch and wait, this is why we're going to get an ultrasound, those types of things. I'll use a pediatric appendix score for that.
Let's talk about pediatrics. So abstract 201 talks about how should we be imaging kids with potential appendicitis. How many people here are using CT scans for kids for ruling out appendicitis? A couple. How many are doing ultrasound or MRI? More. Okay, great. So this is what I'm doing at my institution. In Texas, we actually had two hospitals. One did CT and one did ultrasound MRI. So this question, can it work? Yes, it can. It can work great. This was done at just one Canadian hospital with about 600 kids. 24% ended up having appendicitis, so pretty high outcome of interest. And what they did was all these kids went to ultrasound first. If the ultrasound was confirmatory, either yes, it's definitely appendicitis, or no, it's definitely not appendicitis, they could stop there. If it was equivocal or it couldn't be kind of completed to get a diagnostic answer, they went on to MRI, and they tried to see, could this pathway work? The caveat that they didn't have MRI at night, so this is really only during banker's hours, kind of 9 a.m. to 5 p.m. of when they had it, but they found this pathway worked pretty well. For the folks that had the ultrasound, 60% were diagnostic. So almost half didn't have a definite answer after ultrasound. That's a little low from my anecdotal experience, and I think this comes with the more you do it, the better your ultrasonographers get at it, and your sensitivity or diagnostic rate goes up. But of those, ultrasound had a sensitivity of about 80%. There were a handful of kids, about 20, who had an ultrasound that was read as negative, but the clinician said, I don't know, their exam is still really concerning. Even the fact that I said it was diagnostic, I'm going to get the MRI anyway. They found that those who went on to MRI, it was 100% sensitive, 96% specific. You don't get much better than that. The wait time, they said for the MRI point was 4.5 hours. They didn't say how long it took to get the ultrasound. In my experience, that's really the rate limiting step. Yeah. The MRI takes about 10, 11 minutes. It just depends on your delay of getting through. But overall, they found this approach was very successful in treating kids. You don't have all the radiation that you have with CT. They only had one negative appendectomy and one possible positive one after the MRI was equivocal that was a positive CT. So I think this is a pathway that it sounds like we're starting to implement, at least throughout the United States, and I think is much better for our kids.
Yeah, a couple of things I took away from this was not to get too upset or self-righteous when you get the ultrasound back that says, we don't know still. It's like, really? I just wanted the answer, come on. And ultrasound isn't that great for diagnosing appendicitis. It still takes some clinical judgment, and throwing in an MRI, if you have access to an MRI, can add to that, especially in children, to be able to make the diagnosis.
Absolutely.
A slightly bigger study is the next one. The methods were poor, though. Again, it's pediatric patients of suspected appendicitis. These are extended bankers' hours, 7 a.m. to 10:30 p.m., so it's a little extended there. And they looked at this rapid MRI protocol. And when they say rapid, it's all in context. That means it takes less than 15 minutes to get the scan. It's like saying, how much do you drink? Well, not much. What do you mean by that? And we have rapid strep tests, and so I think people who come in and say, oh, we'll do a rapid strep test, they think, I swab, I have the answer, right? There's still a time delay. So this says a rapid MRI. Now, rapid is relative to traditional times to get the MRI, as in the test itself, less than 15 minutes for these kids. A couple hundred kids, 96% sensitive, so true positives, 98% specific, so again, pretty good metrics there. But 3 out of the 10 positive, so they had 30 positive cases, 3 out of the 10, so 10% were false positives. So they do have a fairly large false positive rate. It was a single center study. The false positives I mentioned, and then there was a few cases that there was an abscess there that the MRI didn't see. So again, this is a little caution that, on the one side of it is like, hey, ultrasounds aren't that great for appendicitis, but also we can't bow down to things like CTs or MRIs thinking they are perfect. There is no perfect test, right?
I think it's close to perfect, though.
It is.
Sensitivity of 97%. If it were my kid, I'd much rather have that than a CT. But they make them really fun. At ours, it's like a space shuttle, and they have like glow-in-the-dark stars. They get a little helmet, and they go in to make them not scared. But the fact that you can get it done, yeah, I think they could. You could go with your Star Wars socks.
With my Star Wars socks, yeah, I'd do it.
All right, so number 2 of 3 said, okay, well, if MRI is not perfect, how can we train ourselves to be really POCUS experts in appendicitis? And we've talked about the limitations of POCUS and of ultrasound in general with appendicitis, because this is a hard one really to see. But those ultrasound enthusiasts, right, they will tell you they can scan down to your mitochondria. They can see everything.
I'm an average sounder. I'm not an ultrasounder.
So what did they find? This was done in Switzerland, and they looked at both radiologists and emergency physicians. And in their practice environment, both do kind of point-of-care ultrasound and looking for appendicitis. They found, similar to the first study we talked about, 60% of cases were conclusive, so 40% that were non-diagnostic. The sensitivity overall, when you looked at the whole group, was fairly high. It was 90%, 94% specific. But again, these were a lot of people who were trained in ultrasound. When they looked at the emergency physicians, they found that the sensitivity was lower. It was 78%. But if you went down to the novice people, probably like us, the average sounders, it was about 50%. So it was kind of flipping a coin. So I think one of two things. One, it's possible. But two, this is a hard test. This is not as accurate as, say, cholecystitis or other things we look for ultrasound for. But the more you practice, the better you get. And that was kind of my experience at our institution, not only for physicians, but our really ultrasonographers. If they're not doing it, they're not comfortable with it, they're never going to get better. And this is one way to potentially reduce radiation and a pathway we can get better at.
And one way to get better is to actually practice very meaningful, very directed ways of going in and doing it and practice, right? This study was done in Switzerland, and so I don't know what the body habitus is of the Swiss compared to my patient population, because I find that with larger individuals, I'm having trouble seeing the appendix and stuff like that, so I don't know about that. They did have another double gold standard, so some people got a CT scan, some people got an appendectomy. That would probably be a really good gold standard, yes or no. And some people had follow-up visit, so watch and wait and see what happened and see if they truly did have an appendicitis. So interesting. All right. The role of perioperative in-hospital delay on appendiceal perforation. So this is now you have the diagnosis. So we're not going to talk about, like the ultrasound, 60%, stuff like that. This is, it's appendicitis. Can you wait to take out the appendix? And there was a flurry of studies in the last 5 years with the concept of NOTA. We are NOTA going to take out your appendix today, right? And treat them with antibiotics, so non-operative treatment of appendicitis. And there's been some studies both in adults and in children. Probably in the last 10 years there's been a movement for a very specific type of patient. This one was saying, do we have to do the appendectomy now, or can it be delayed? And basically this is like, can we do this in the morning? Do we have to do this, bring in the surgical team at night and do this now? So they looked at scheduling within 8 hours of randomization. So we're going to get this done in the next 8 hours. That's the goal. Randomized, so it's a randomized control trial. Or we're going to schedule it within the next 24 hours. So beyond the 8-hour time period. And we want to see how many people perf. And there was 1,800 people in the study. Perforation was 8% basically in both groups. 8% in both groups for early versus delayed. Now, it was an open label design. You knew if you went and got your appendix out, right? But I'm not sure that makes a big deal. But the difference between the two, this is what I want to point out, was only 8 hours. And so the difference, it wasn't like one group got it done at 1 hour and everybody else got it done at 24 hours later, because it was up to 24 hours. And in fact, in the delayed group, a quarter of them got the surgery within 8 hours. So again, that gets me thinking of, these people were coming in the evening or overnight, and then they were just going to take out the appendix the next morning, load them up with antibiotics, and then take it out. I don't want this paper to be over-interpreted by our surgical colleagues or by ourselves going, we got up to 24 hours, just let it ride. That's not what this says.
Right. And that's hard. Whenever we do a study and you have treatment A and treatment B, if a quarter of your people that were supposed to get B actually got A, then it kind of confuses those results. So to talk nerdy for a second, there is something called this sort of intention to treat versus kind of a per protocol analysis. And I was a little disappointed they didn't do that, but you have to plan for that ahead of time and make sure you have a big enough study population. But essentially what they would have done is that if people actually got 24 hours, let's look at that subset of patients versus those that got it early. But I think this is one of two things. One, it's the surgeons just want to finish their round of golf, right? They don't want to come in right away.
No.
Or wait, I don't want to come in at night, right? Nobody does. But we are seeing a number of diagnoses that are changing, right? Open fractures. Who remembers when open fracture used to be an emergency? They would come in the middle of the night to wash those out. Yeah. Now, not anymore. The study said, nope, those can wait. I'd rather sleep. I'll come in first thing in the morning.
And be fresh and be caffeinated and the team's up, and it's not what's going to do that to the rest of your surgical list the next day.
True. So on one hand, I'm sort of relieved because in my ED, there's no way the patients are going up in 8 hours. Although I think I'm more curious, not necessarily the time from diagnoses, but how long were their symptoms, right? The ones that perf, were they symptomatic for 2 days first and then they came in and they perfed? Because that's really the outcome.
Yeah, if they've had symptoms for a week, or today I started noticing some periumbilical pain, now it's gravitating towards the right lower quadrant. That's a different
question. And I think that's more relevant to us, and they didn't ask that. So I think we still don't know, but it gives us a chance to say we can give them antibiotics, we can hold them in the ED, and hope the surgeon comes in eventually to take care of it.
And I think that adds to that whole non-operative treatment. And I think that non-operative treatment, that's not the decision I make. That's a decision between the patient and their surgeon, not between me and their surgeon. And when patients ask, I said, I'm a physician, not a surgeon. Yes. I'm a doctor, not a, sorry, that's Star Trek. But to do that, I prep the patient to say, the surgeon may suggest treating this with antibiotics. That's not crazy talk.
Are they doing that in Canada where they're just doing antibiotics?
Yeah. Oh, yeah.
Any of you at hospitals where they're doing just antibiotics for kids? And where are you guys? University of Kentucky, yeah.
Yeah, so we do that, and that's why I've learned to prep the patient in advance for when they have the conversation with the surgeon, if that's on the table of one of the things the surgeon thinks is a surgical option. But it is surgeon dependent. I work in a number of different areas, and some surgeons are like, of course I'm taking it out.
So we tried it for a while in San Antonio for about a year, and we found that our recurrence rate was like over 50%. So
over 50, yeah.
So when we just put them on antibiotics, they got better, we sent them home. They came back sometime within the next 6 months with an appendicitis. And so we're like, if you're going to get it out eventually, they kind of went back to we're just going to take out your appendix.
We're just going to take it out now.
Yeah. So to repeat that, in Kentucky, within adults, they're doing a little bit more, and with maybe the older kids, the younger ones, they're still taking to the OR, but there is a subset of patients who are there doing just antibiotic treatment to see, but not all. Interesting. We'll see where our practice changes. Well, 205, again, these ultrasound enthusiasts, now we're looking at what is our ability to perform ultrasound in acute cholecystitis. How many people are doing their own ultrasounds, or at least trying to look at the gallbladder before we send them? It's a fair amount.
I'd give it a try.
This is one, again, the more you practice. I love looking at gallbladders. The bile duct, though, is for me very difficult to find. But this kind of shows that this is a group that we can actually start seeing something, although we're maybe not perfect at it. This was a study that came out of an EM group that did a systematic review. It's a meta-analysis, and they had 10 studies, but 5 of them were retrospective. So again,
all of them were observational.
Yeah, so when you're combining all these, again, poor studies, garbage in, garbage out, it kind of makes it very difficult to kind of understand how this actually makes sense. But if you take their numbers for what it was worth, using a reference standard, the sensitivity was 71%, specific 94%. So it's one that if you see stones, you see wall thickening, it's probably highly specific, that's probably cholecystitis, but the sensitivity was really not very good, meaning if you have a totally normal study, there's a chance it's still cholecystitis and you're just not seeing it. So they're saying that it's moderately good for ruling out, but not good enough to rule in. I'm not sure this study definitely answers it, and again, it's going to very much depend on so many other factors. When these are observational studies, we don't know were these patients obese. We don't know if they ate an hour before they got their ultrasound. We don't know how skilled the ultrasonographer was, if this is someone who's a resident, someone who's been doing this for years, are they fellowship trained? So there's so many variables in here that are hard to adjust, but I think we still keep practicing.
And if you say it's the resident who did it, they're probably better at it than I am. It's not like it's the resident. It's the resident. Yay, they're better at it than I am. But not only were they observational studies, but 9 out of the 10 were convenience samples. And so again, that introduces some selection bias. So that means that there could be potential bias for, I'm going to pick and choose which patients I'm going to include in this study to do the ultrasound. So you might be cherry picking the best cases possible. And so I don't think this gives us the answer.
Convenience samples, to be fair, though, are almost all of emergency medicine studies, and it's because many of us don't have research kind of people who can enroll people at night, so we're selectively picking people during the day. But theoretically, you could get a different patient population or a different type of acuity during the day than at night. But just so you're aware, almost all emergency medicine studies, by definition of the funding and sort of opportunity to enroll,
and so to address that, if we're going to do emergency medicine research, we should properly fund the research to investigate the populations that we serve, and that means 24/7, 365.
Good luck with getting funding.
You're welcome.
But yes.
Yeah, no, I'll continue to advocate because we need to do better research, not necessarily more research, but better research.
Agreed.
All right, am I comparing acetaminophen to ketamine or ketorolac versus morphine for acute renal colic? And Gillian was nice enough to talk about network meta-analyses the other day. And so this is a network meta-analysis looking at adult patients and comparing IV acetaminophen to IV ketorolac and IV ketamine. Who here uses ketamine? No, I don't mean personally, sorry. I meant, for your patients. So, and so I have not thought, have you thought about using ketamine for renal colic?
Not for renal colic.
I've used ketamine for patients, of course,
but not for renal colic.
But I haven't thought about using it for renal colic. And so they were looking at what evidence was available for that, and they compared it to morphine. 12 randomized control trials, not the direct comparison, it's a network meta-analysis. And their primary outcome was pain at 30 minutes. Pain relief at 30 minutes, depending on the treatment modality in these 12 randomized control trials with almost 3,000 patients. The most effective treatment at 30 minutes was ketorolac. Acetaminophen was better at 15 minutes, but that wasn't their primary outcome. And if you have lots of different not primary outcomes, but you have lots of different outcomes just based on the statistics, right? Going up and down, one might look a little better. But when they said 30 minutes is our key, ketorolac came out on top. Same thing at 60 minutes as well. Which one of those do you think had the highest side effect profile? Acetaminophen, an NSAID, ketamine, or morphine? Morphine. Yeah, morphine had the most adverse events there, so not too surprising. Now, the studies, it was a network meta-analysis, like I said, and there was a lot of variability in these studies. They didn't titrate the morphine, they just gave a standard 0.1 milligrams per kilogram, that's what you get. They didn't titrate it up, and we all know that some patients are a little bit more sensitive than others. I can give a whiff to somebody and they're thunk, and I can give, let's drop the rhino dose, and they're still going, I'm still in pain, doc. Right? Like it didn't even touch them. And so they just gave a standard dose. It wasn't titratable.
I think there was a lot of, sorry, go ahead.
I would have to go look it up, but I think it was probably the 30 milligrams, but I'll look it up for you.
I think the hard part, there was a little bit of a language barrier with the study. They kind of overlapped some of the treatment arms, and like even their conclusions seemed to sort of contradict themselves. Like on one hand, they said ketorolac works best, morphine has the highest adverse event, but the best treatment for the best pain control with the least amount of adverse events was when you combine ketorolac and morphine. So they're kind of like going back and forth. So this doesn't change my practice. I'm a big fan of the Toradol, ketorolac plus the morphine. These can be incredibly painful, and that seems to help quite a bit. For those who are using ketamine, like what dose are you using for ketamine for renal stones? Are you doing like a dissociative dose? Is it like the 0.3?
The sub-dissociative?
I'm curious what people are doing for that.
Is anybody using it for renal colic? Or biliary colic, sorry? Renal. So you started off with a sub-dissociative dose of ketamine for renal colic. It didn't work very well. And did you go up? Did you go up to a dissociative? Yeah.
Wow. So I think your practice, what do you do?
Oh, so usually we have some standing orders for the nurses, and they often will give ketorolac up front, before I get there, because, to address the pain early and stuff like that. And then by the time I get there, I can assess how was that effective. Most of the patients that have come in have already tried oral acetaminophen or oral NSAIDs, and so then I'm going to an opioid, and I have a little thing of give them 0.5 to 1 milligram of hydromorphone Q15 minutes times 3. And then assess the patient, get all their blood work going, and then go see another patient and let that nurse work with that patient to titrate their pain medicine effectively.
I thought there was some data that showed that it worked best when you use them kind of synergistically together, but I've been surprised by the number of people who get ketorolac who then don't actually need the opioid. They get better with just the NSAID. And
is that just the natural history of the disease? I'm in terrible pain. Yep. I'm really, really in your face about, I've got a lot of pain. And so, we got to get them something, and we get them something. 15 minutes later, they're feeling better. Is that the colic? Is that the natural history of the disease? Or is that ketorolac?
Who knows? Well, should we wrap up?
Wrap her up. Oh, sorry. That means going to the front, right?
Yes.
Right back to the front. Okay, so bottom line, ignore appendicitis scores. You're better than that. You've got this. You're good clinicians.
But if you're going to need an imaging study, using ultrasound and then an MRI pathway has shown to be useful. It looks like a number of us are now using that in our clinical practice and will reduce the incidence of radiation from CT.
And we're getting more and more places that can use MRIs or have MRI protocols for these children.
In some countries, you have emergency physicians who are regularly doing ultrasound for appendicitis. That's not my practice yet, but there's some data to show that it can work and you can improve over time the more you practice in being able to actually diagnose appendicitis with ultrasound. And be aware that even though the decision is to take out the appendix, there's some loosening to how urgently, in the next few hours, or can we, sort of delay it a bit and do it during other hours, but get the antibiotics on board. Doing POCUS for acute cholecystitis is becoming more and more kind of common practice. We're teaching it nowadays where our residents have to do a number of scans before they graduate. There's data in this meta-analysis, mostly observational studies, to show that we're good at sort of ruling it in, but probably not high enough sensitivity to rule it out. And so when it comes to treating colic, ketorolac seems to work the best, but we need better studies.